Yeah, sorry about that. The Wi-Fi was dwindling a bit. So the right-sided chambers lie anterior to the left-sided chambers. The atria are to the right, and 1/3 of the heart also, as you can see, lies into the right side of the thoracic cavity. Yeah. So the heart has a right border, as you can see over here, an inferior border, and a left border. It has an anterior surface or a sternocostal surface, an inferior or a diaphragmatic surface, and posterior and above to the inferior surface, it would have a posterior surface. This is bordering over the atria, superior and the inferior vena cava, entering into the right atrium. The inferior border or the diaphragmatic area is formed of the right ventricle. The posterior surface, the slip formed of the left ventricle. The right atrium, the inferior border of the heart, is at the apex. The inferior border of the heart is formed of the left ventricle. The left border of the heart is mostly the left ventricle, with the little contribution comes from the auricle of the left atrium. The apex of the heart is at the junction of the inferior and the left borders. The intercostal surface or the anterior surface of the heart is mostly the right ventricle with the atrium on the right side and a narrow strip of left ventricle at the top left. Inferior surface consists of the diaphragm, or the diaphragmatic surface is 1/3 left ventricle separated by the posterior interventricular branch of the coronary artery. The posterior surface is entirely the left atrium, which receives the pulmonary veins, which you can see in this diagram below. This is the posterior surface. You can see the pulmonary veins entering into it. This is the left atrium. And just underneath which you can see the coronary sign. बीच में से कहाँ से आ रहा है smooth. Okay, so just underneath the left atrium, you can see the large coronary sinus, which is the largest vein present in the heart. Right atrium lying between the superior and the inferior vena cava, forming the left right border. The upper part is extended to the extends into the superior vena cava, which is right here. And there, at the angle of the auricle, where the auricle meets with the atrium, there is a sulcus called the sulcus terminalis, or the terminal sulcus, which when opened, when removed, you can see the crista terminalis underneath the sulcus terminalis. Now, once you open the terminal sulcus, you find that underneath there is the crista terminalis, and next to it is the rough area formed of the musculi pectinati, or the pectinate muscles. The smooth walled area lying just lateral to it is the area that is formed because of, in the embryological state, when the sinus venosus gets incorporated into it, that gives rise to the smooth walled surface over here. Just underneath this area, on the interatrial septum, this is the septum that lies between the two atria, you will find the fossa ovalis, or the limbus fossa ovalis. This is the limbus fossa ovalis. This is formed of the septum primum over here. The septum secundum over here. The septum primum lies on the opposite side. So the opening of the vena cava are into the superior and the inferior parts of the atrium. Just above the opening of the inferior vena cava, we come across the coronary sinus, which drains the opening of the coronary sinus over here, which also drains the other veins in close proximity, lying in very close proximity to this coronary sinus. This is the interatrial septum, or the posterior wall. And in this diagram over here, you can also see the limbus fossa ovalis and the septum primum over here. Right next to it, you can see the atrioventricular orifice with the valve leaflets. And in the wall, you can see the crista terminalis along with the musculi pectinati. So the right ventricle projects from the left to the right atrium. The atrioventricular groove is runs vertically downwards, and as it runs vertically downwards, it takes a backward turn, goes all the way posteriorly onto the diaphragmatic surface. And in this atrioventricular groove, we have the right coronary artery running into it, running through it. You can see the large vessels, the aorta, and the pulmonary trunk arising from the right ventricle over here. So the right ventricle, so when the wall is removed, the papillary muscles are exposed. You can see the papillary muscles, which are 3 in number, and the anterior and the posterior and the lateral papillary muscles, they give out chordae tendineae, which attach to the valve leaflets and regulate the movement of the valve. Now, one of the ridges break free in the from the interventricular wall, and this ridge becomes a thick band, which is called the moderator band, or the septomarginal trabecula. The papillary muscles are attached to the wall, and the other, through the chordae tendineae, they attach to the cusps of the tricuspid valve. The tricuspid valve is large enough to admit 3 fingers through it. So it's the larger valve of the 2 AV valves, the tricuspid and the bicuspid over here. This is the larger of the 2. The cusps are anterior cusp, a posterior cusp, and a septal cusp. The edges of the cusps are attached to the chordae tendineae, coming through the papillary muscles. The papillary muscles are attached in turn to the wall. The cavity of the ventricle, of the right ventricle, is crescentic shaped because of the impinging wall of the left ventricle, the thick muscular wall that impinges into it. It gives the right ventricle the form of a crescent, as the left ventricle is larger and more circular. The cavity of the ventricle continues into the funnel-shaped conus or the infundibulum, which then leads to the pulmonary trunk, and which is guarded by 3 valves, the semilunar cusps of the pulmonary valve. Left atrium forming the base of the heart. Lying behind the right atrium, you can see the right atrium, right auricle, and the right atrium. The predisposition is such that the right atrium lies in front and the left atrium lies behind it. And the left ventricle slopes down from below the left atrium right up to the apex over here. At the junction of the left atrium and left ventricle, you can see the coronary sinus, which drains all the way into the wall of the right atrium. The left auricle projecting from the left side of the infundibulum, part of the infundibulum, and this is the left ventricle opening up. This is the opening of the left ventricle with the anterior and posterior septum cusps over here. 2 fingers within its opening. The anterior cusp lies between the mitral and the aortic orifices, which would be this one. So the left ventricle has a cavity with much thicker walls. The walls are almost 3 times thick compared to the other ventricle. Here you can also see the trabeculae carni, which are well developed. Because since there are 2 valve leaflets, there are 2 papillary muscles present to regulate the movement of the valves. The interventricular septum, this impinges into the right ventricular cavity, giving it the crescentic shape. You can see the left atrium over here. It permits the pulmonary veins into it, and anterior to the atrium, you would find the much smaller left auricle. So aortic valve again consists of 3 valve leaflets, and these are also semilunar, with cusps over there, semilunar cusps, which you can see very clearly over here. The 3 valve leaflets, they're semilunar cusps, And in the center of each cusp, there is a small lunule present. And when these cusps they come down, these lunules are approximated, and it's the weight of the blood that brings down these cusps, as you don't see any chordae tendineae attached to them. The fibrous skeleton of the heart is in the form of a figure of 8. And it is this fibrous skeleton to which the valves, all the valves, the 4 valves, the AV valves, both the right and the left AV valves, and the pulmonary and the aortic valves are attached. Along with that, the interventricular septum, which the membranous part of the interventricular septum is also connected to this fibrous region. And only the AV bundle is the only communication between the atria and the ventricles. Otherwise, there is no communication, and these are regulated independently. The AV bundle helps regulate their movement. So the structure of the cusps, the tricuspid and the mitral valves, you would notice that these tricuspid and the mitral valves are pretty much flat, and they're not semicircular with lunules over here. They are connected through the papillary muscle, through the chordae tendineae to the papillary muscles. And in contraction, their edges come into contact with each other, and the chordae tendineae restrict their movement so that these would not collapse into the atrial cavity, thereby preventing regurgitation. This is the right AV valve with 3 cusps. This is the left AV valve with 2 cusps. As I mentioned earlier, these are the aortic valve cusps. And the lunule in the center, then these are tapering downwards at an angle of approximately 120 degrees with the horizontal. And between the at the attached margins of the cusps, you would find the openings of the coronary sinuses, the right and the left coronary sinuses. Openings are present at the aortic valve cusps. So a little bit about the surface anatomy. The surface anatomy of the heart is from the midline, 1/3 of it projects into the right side of the cavity. From the lower border of the 3rd right costal cartilage, drawn perpendicularly downwards up to the 6th costal cartilage, with a slight convexity towards the right is the right from the 6th costal cartilage straight left side of the cavity in the mid-clavicular line. You would find the inferior border from the third costal cartilage on the right side to the 2nd costal cartilage on the left side. And there, from the 2nd costal cartilage, we join these 2 points, the inferior border and the superior border, and that completes the whole demarcation of the heart. Now, since I mentioned earlier the atria lie behind each other, the right atrium lies in front, and the left atrium lies just behind it. Similarly, the predisposition of the valves is also the same. The tricuspid valve lies anterior to the bicuspid valve and of the sternum, body of the sternum. And since the pulmonary valve lies on top, anatomically, you would see the valve, surface marking of the valve of pulmonary valve right on top, just below which you will find the aortic valve marking. These the positions of the tricuspid, the bicuspid, the aortic and pulmonary valves behind the sternum in no way tells us that the sound would be best heard on these locations. In fact, the sound of the heart valves, the aortic heart valve is best heard at the second right intercostal space, and the pulmonary valve is best heard at the second left intercostal space, whereas the tricuspid valve is best heard between the just lateral to the manubrium in the right, between the right sixth intercostal space, and the mitral valve is best heard at the apex of the heart. These are the areas where the heart sounds are best heard. The tricuspid valve over its surface over here. This is where the stethoscope should be placed while oscillating for the tricuspid valve. And for the mitral valve, it should be at the apex. This is the apex. And this is where the for the pulmonary valve, this was for the aortic, and this is for the oscillated in this region onto the left. And this is where we oscillate for the tricuspid and the mitral valve in this order. Back up. Sorry about that. So the aortic sinuses are present at the beginning of the ascending aorta. The right coronary running into the AV groove or the atrioventricular groove at the inferior part of the heart. It goes all the way backwards and runs posteriorly within the same groove. These are some of the branches of the right coronary artery. You can see the nodal branch, AV nodal branch, You can see the right marginal artery over here. In about 60% of the cases, comes from the left coronary artery. So the conus artery over here, it goes and most of the time it joins the conus artery coming out from the left coronary artery. Anastomosis with the the synodal arteries from the coronary artery from the left coronary artery. So the branches of the right coronary artery would be the right marginal artery, which is present over here, the posterior interventricular artery, which is also called the posterior descending artery, the AV nodal artery, and some of the ventricular branches which go away into the left ventricle. Left coronary artery arising from the left posterior aortic sinus behind the pulmonary trunk. It emerges and divides into the terminal branches, which would be the circumflex branch and the left anterior descending. These are some of the branches of the left coronary artery. This is the point of origin of the coronary artery with the anterior interventricular branch, the circumflex branch, which you can see over here, marginally posterior branches over here. Then we have the anterior interventricular, which is one of the main branches of the left coronary artery. Left coronary artery. The anterior interventricular, I mentioned earlier, is also called the left anterior. That is mostly gets clogged due to atherosclerosis and may give rise to myocardial infarction in the area which it supplies. Then there is the anterior interventricular, the left conus, diagonal and ventricular branches, which I've already mentioned earlier. Left dominance is when the left coronary artery gives rise to the nodal artery. 40% of the cases. That also happens when the right coronary artery in 10% of the cases is shorter, and the posterior interventricular artery, which is a branch of the right coronary, is replaced by the circumflex artery supplying the AV node. And the right dominance is, of course, when the right coronary artery supplies the SA node, giving off the posterior interventricular branch, and thereby causing it to be dominant. Anastomosis at the arterial level exists between the termination of the right and left coronary arteries in the AV groove and between the interventricular and the conus branches, which I did mention. Some anastomosis exists between coronary arteries and pericardial arteries around the roots of the great vessels. So the veins of the heart are the coming from the large coronary sinus. These drain through the great cardiac, the middle cardiac, and the small cardiac veins, some of the oblique veins, and into the coronary sinus, which opens into the right atrium. in the posterior wall just below the fossa ovalis. All of these would drain into most of these would drain through the coronary sinus. Some anterior cardiac veins would drain directly into the atrium, and some of the veni cordis minimi also would drain directly into the right atrium. So the coronary sinus would receive most of the blood through the wide vessels and lying into the posterior part of the interventricular groove, and it's covered by a thin layer of the myocardium. Some of these, the coronary sinus also open to the right end of the posterior wall of the right atrium, which I had mentioned. The great cardiac veins would accompany the anterior interventricular and circumflex arteries. They receive a number of ventricular tributaries before they open into the coronary sinus, through the coronary sinus. These middle, small, and cardiac veins open next to or very near to the coronary sinus. Some of the posterior veins of the left ventricle also join the sinus to the left of the middle cardiac vein. The oblique vein also runs downwards close to the sinus near its left end. Okay, so with this, we come to the end of this lecture. Thank you very much.
Strength.